We want to shift topics now. We talked a little bit about physician unions, helping the employed physician. We now want to talk about accountable care organizations, and I asked Dr. Philip Gaziano to speak to us. This colored paper in there is from him, and you're welcome to peruse that and read that as you are listening to this. Accountable care organizations are, as you know, are a part of the Affordable Care Act and encouragement, something that we're considering as a Utah Medical Association if the physicians of the state would like to do that. I'd like to introduce Dr. Philip Gaziano. He's the chairman and CEO of an Accountable Care Associates, which develops healthcare IT and care coordination solutions for care providers, provider groups, hospital system, payers, and governments. In addition to being a co-founder of ACA, Dr. Gaziano founded Quality Health Ideas, which partners with ACA in providing data services, web-based tools, and integration services for ACOs, medical homes, and other newer payment models, and multiple global delivery programs. Dr. Gaziano is an internal medicine specialist and geriatrics subspecialist and has an appointment as assistant clinical professor at Tufts Medical School. He's been a medical director of a health plan and a multi-specialty physician group, an IPA, an acute rehab hospital, an LTAC hospital, skilled nursing facilities, and home care agencies.
For a little bit of discussion and questions. Can you hear me okay?
Yes, we can hear you now.
Okay, thank you very much again. I will leave time for some questions and discussion. I wanted to introduce our multiple organizations, which are all physician-owned, 100% physician-led, started in New England and now providing a network of grassroots providers, physician organizations joining us across the country. The first of the organizations we put together, my wife and I, my wife is a primary care physician who also did a doctoral thesis in informatics, and I'm a geriatric specialist, internal medicine physician. And my wife and I put together
Quality Health Ideas to share data. I'll tell you about that. And we founded it in '97, and it has web data analytic and sharing tools that work for managed care. We developed the clinical case management, disease management, reinsurance support network for other physician groups and our own in ACA, starting in the 90s and then becoming a separate organization in 2010. And in 2012, we founded the Medicare Shared Savings ACO, which is Accountable Care Clinical Services, which a lot of physicians are now joining. And most recently this year, HIE Incorporated stands for Health in Evolution, and it houses our own HIE and other tools. So I'm going to share with you what these groups do and how we're bringing physicians together. Quality Health Ideas, as mentioned, started in '97. In 2003, it developed CareScreen, a data sharing tool that is cloud-based. My wife and I designed it, and it adds integration into any type of EMR, clinical services, and helps physicians, practices, IPAs perform in Medicare Advantage or ACOs. The clinical side adds to that this set of contracting, care coordination, reinsurance, coding, risk adjustment, the other tools that you need to do a global contract of any type. The ACO, which is Accountable Care Clinical Services, now has about 1% of the PCPs and I have to update the slide. We're now up in 12 states and is growing fast. I'll give you a little information a couple slides later. And lastly, the Health and Evolution Company is here to support practices with other practice services, including EMR, ICD-10 transformation, and other services. Here's how they're set up. I won't go into that, but we also have a research arm and programmers in the U.S. and India to help keep the data tools working and hook up to physician practices. Here is a little bit of the outcome and just the proof that it works and they work together. We are rapidly growing to serve almost 500,000 members so far, and our physician network in 12 states has 1,500 PCPs, 50,000 specialists, all in our network, connected to 50 plus hospitals. We do have some that are partner hospitals and share risk, and we're managing a growing number of members. What's interesting is our way of coming together. A lot of the consultants said couldn't be done at all, including half of the physicians are in groups of 1, 2, or 3, and 20% are still on paper charts. The others are on 40, 50 different EMRs, and the EMRs don't talk to the hospital records. The only connection for our network is the web tools that use our own messaging, but the outcomes we have, which I'll show you in a minute, compare favorably with the big hospital systems and big practice aggregations. What's good about our providers is that they're managers themselves. The fact that many of them are still running their office or their practice means that they're able to manage other things, including budgets, including Medicare budgets, and we give them the tools, and we haven't found a set of providers where it doesn't work. The providers who are with us want improved quality, but want to retain control and compensation and satisfaction. They want to help solve problems, fix delivery, and save and preserve private practice. These are the programs that we help with. We help with Medicare Advantage. We do managed Medicaid, dual eligible, Medicare, Medicaid. And the ACOs, I'll tell you more about ours, but we also help give tools to another ACO if another state or group wants to set up theirs and just needs infrastructure. The commercial systems, we were the first in New England to do the Blue Cross and Blue Shield of Massachusetts alternative quality contract. We work with PPOs, including one with Unicare, and work with self-funded and government programs. So we haven't found a population that doesn't benefit from this management, and our tools and way of linking practice together seems to produce good outcomes and is easy to roll out. Why the change? Why us? In general, the buyers of healthcare, the federal government, states, employers like General Motors, self-pay, need new solutions. There's $1 trillion of waste, and quality and satisfaction isn't what it should be. There's an existing management infrastructure, mostly in large health plans and large hospital and other systems, but it's not effective. It's not really saving the $1 trillion. Private practice is under attack. So We think that we're actually helping to straighten out the tracks and provide new management, which we're part of, but we're actually saving some of the budget waste and having improved outcomes for the triple aim. In the process, our way of doing it actually preserves and improves private practice, which is different from other forms of integration. What we've been building is this, and it's been 18 years in the making for us. We have outcomes that exceed a lot of the big systems. We have our own tools, and we're ready to help manage whatever part of the country wants to come with us. We have a performance track record among the best outcomes in Medicare Advantage for almost 20 years. We've gotten experience in Medicaid and dual eligible. I'll show you the results of that Blue Cross Alternative Quality Contract, which is an ACO type of model, and I'll share with you how it's put together and what we've done with it. We've been growing yearly since 2010, and actually in the last year, our physician network and our members have doubled every 4 to 6 months. Our way of rolling out the products is rapid and real time. We give sign-on and get practice up and running in a matter of weeks or months, and we don't want to incorporate the practice. We want the providers to keep managing their own practice. We just want to bring the new contracts and new results. This is a report card that the health plan, Tufts Health Plan, asked Deloitte to come in and look at the large networks in the state, and most of them were the big Boston groups, including Atrius and MacGypa and Partners. One of these actually is under us now, and we were shown both in the areas of incentives, how we pay the physicians. We never have a withhold, always start with 110% of Medicare. If it's a Medicare product, we get the PCPs, typically 200% of Medicare. The physician engagement and leadership, case management, disease management, and the web tool, that care screen, were noted by Deloitte as being as costing less than the other forms of integration, but having good outcomes, including savings. Well, here's a little bit about why we think they work so well. Our care coordination, which has had among the best outcomes for Medicare in a decade, it's closer to the providers. Our nurses and care coordination staff really work as an extension of the physician offices. We have specific programs for populations. We follow NCQA. We have unique models. When we do care coordination in Massachusetts, we actually are delegated by the health plans to do their authorizations, denials. And when we do it out of state, we sort of guide the care. But in any case, we do it more connected with the physician office. We've been very good at defining the different populations. Some entities focus on the train wreck, the top 0.25% that has an unfortunate cancer or an unfortunate accident and spends 6 months in the ICU. That's actually not where you're going to do a lot of saving. Good medical care, whatever they need, you don't need to scrimp. The next group, which is the top 3 to 5%, just below that one unfortunate individual, which you're going to have every year and a half, and you get reinsurance for that one. But that next 3 to 5%, those are the chronic disease, CHF, COPD, renal failure, diabetes. Those go in and out of the hospital and spend about half the budget. We have preventative programs and pharmacy management programs, and we pay attention to some of the psychosocial and psych and prenatal issues that others don't track as well because we're closer to the practice. And we also are good at getting the care at the right level of care quickly. So by doing that, we have savings. There's the data tools, our combination, each component works well. Each component is designed with the busy provider in mind, and they work with each other. Our case management component works with the PCP, module, and that can be used whether you're on a paper chart or any different EMR. It pops up in whatever you have. This is some of our predictor. We have algorithms based on 20 years of experience that can project down to the member or the individual physician or group level whether we're in surplus or not. And these can predict. Some of you who are in the management industry know that the IBNR, or incurred but not reported, is tricky to report. We're among the best, even compared to some of the larger tools like Optum and others. We pioneered and invented a payment system that we put on top of the RVU. What I realized after a while was that a fee for a service isn't necessarily bad, but that the old fee for service, which was based on the RVU, it's actually the RVU that's the problem, because it doesn't assign a relative value unit or any payment for case management activities, calling the case manager, addressing multiple chronic conditions, when if you address one acute condition, you'll get your level 4 visit, looking at the registry, doing extra prevention, looking at the pharmacy, changing to generics. None of those, or even looking at referrals, none of that has any value in the RVU system. So we assigned a quality value unit, and we actually give payments for that. When we did that, in addition to PCP incomes doubling, you spend an extra 5 minutes, make a 15-minute visit, a 20-minute visit, but get paid for 30 minutes. When we do that, more other good things happen. And here's the outcomes. So these are for that Blue Cross program, which is a commercial program, but it's on an ACO model, and the AQC stands for Alternative Quality Contract. What we found was it didn't matter whether the group was large or small. We have some multi-specialty 100-provider groups, and we have some solo. Didn't matter whether they were on paper chart, EMR, Epic, Athena, didn't matter. What mattered is, did they turn our CareScreen web tool on once a year for 5 minutes? If they did, the quality scores markedly improved, and the savings, and that savings in the higher group is $33 per month per member. And last year, for our 50,000 members, we had to split up $24 million among the physicians for this particular contract, giving some physicians over $1,000 per member of added P4P and surplus on top of their fee-for-service. Here's what we did to the overall budget for that Blue Cross commercial contract. Before we started, we were horrible. We were 7.9% year after year inflation for the cost for that commercial population. We attempted to keep it below 5.5%, and our last 3 years it was about 0.5%, and our 5-year average 2%. So that's why we had some good savings to split up, and all the quality scores went up. By the way, I'm one of the members. I actually have this insurance. My family and I actually like the extra phone calls that our nurses gave, and my PCP last year called me up and said, time to get your colonoscopy, and said, Phil, it's not about you, it's about me and my quality score. but it does work. Here are some of our outcomes for Medicare. Remember, I mentioned that top 3%, typically unmanaged, will spend 50%. We save on 6,000 members in Springfield, Massachusetts, $10 million on those alone. And we saved about $12 million altogether on that population for about a quarter of the budget. And we've done that consistently for a decade. This shows the risk-adjusted factor for Tufts Medicare Preferred, the largest in our state, and it shows the numbers just based on CareScreen use. The rest of the health plan network in the state does not use CareScreen. Here, in the lower left, down at $39 and $49 negative, are groups on, one is on Epic, one is on Athena, all of the population modules, big HIE, and they didn't use CareScreen. Up in the upper right are some small practices, half on paper chart, and those were their savings per month per member for Medicare Advantage. Again, because they used the web tool and followed the instructions. This shows the savings per member per year for that Medicare Advantage, and again demonstrates that that lowest group, by the way, all on Athena. Not that Athena's bad. Our tools show information that no EMR has, and the top group that were smaller practices not connected, and a third of them were on paper, had more savings per year. This is an interesting slide because it shows one of our multi-specialty group practices. They have 50 physicians, but if you look at it, the 5,000 members, there are 16 PCPs among the 50 physicians, and the 16 PCPs together have about 2,000 members in each panel, and so their total panels add up to 33,000. What's interesting is, yes, it's a little more work because 16% of the members took 19% of their time, since I asked them to do an extra 2 or 3 minutes on top of each visit, but that 19% represented 1 day a week out of their practice, and it brought in more revenue than the other 4 days a week on fee-for-service. Almost like a concierge practice, but this is with regular Medicaid, Medicare Advantage, and that Blue Cross. And the reason we got them the extra payments is we did give the same RVU payments for their fee-for-service, but we added those quality value unit payments, plus we gave them surplus and money actually to manage their own patients. Our Medicare ACO, it's now becoming one of the largest in the country. It is the fastest growing. It was designed as a modular, non-contiguous, coast-to-coast, and we successfully reported on 130% of the quality measures we had to, the extra 30% for good measure, and we're one of the few that appears to have a first-year surplus, and we seem to have a surplus, according to CMS, of about $10 million on our first 20,000 members, although now we're up to almost 50,000. Every quality measure improves. All practitioners, anyone in our network, we haven't found one, even some of the skeptics. We actually, help pick up things that would fall through the cracks. The members noticed. The health plans and employers noticed. And we got the most improvement when we started adding those quality value unit payments. A nice side effect is that liability improved, and that same physician group I showed you earlier was able to receive a 40% reduction in malpractice premiums for the same coverage because of these systems. Partly because our case managers and the tools themselves pick up stuff that falls through the cracks better than a a medical home, and it works even if you all you have is a paper chart and a browser. But the health plans noticed, again, adding the extra payments for quality value unit activities helps. And lastly, these are some of the other systems that we help provide to practices, just to make sure they know they can stay independent. They don't need to join a large system or sell their practice, and will help them outperform some of those big practices. So that's a bit about our background presentation. I'd like to open it up for question and discussion.
Pass any of your cards up if you have some.
I'm going to ask you to try to repeat the question closer to the mic of the phone so that I can hear it.
I'm going to have Mark Fotheringham raise the questions, and then you'll hear the question, and you'll also hear the answer.
Dr. Gaziano, can you talk a little bit more about how a solo physician or small group can participate with your organization's ACA but remain independent? And then describe specifically how we could participate with Utah insurers through your organization, or how that works.
Sure.
Good question. The number of solo practices is the largest of our practices by type. We have several solo practitioners or 2-doc practices. We can have them join our federal Medicare ACO. We can, if there are several in the same town, we link them together as a pod or a little network, and we're doing it, in state after state. We can take a large group practice. We can take a whole county. Sometimes a county foundation or medical society will offer it to all their independents. Doesn't matter to us. We can give that individual practice the sign-on to our web tools. We would come in and actually, if they have an electronic record, if they're joining our ACO at our expense, we'd hook them up to the sort of backdoor connection as well as the web tool, so that it pops up automatically. We also, if we have more than 5 or 6 physicians in a town, we'll hook up to their hospital. Again, we provide that service. We don't ask for the physician doesn't pay for it. We then, because they join a network, ours, we are allowed to go to the payers or healthcare buyers and ask if that payer wants to work with this group of physicians and us to support the tools, give increased payments, QVU payments, management payments, and because the health plans know our track record and our outcomes, they're often incented to let us help them by managing, and our brand of managing always gets the physician network increased payments, and the plan improves their margin a little bit, so they're okay. This is one of those where it can be win-win-win. By reducing expense that really shouldn't occur anyway, bounce backs to the hospital, by reducing costs that really hurts care, we can redistribute, and the state or the federal government or the health plan and the physicians all benefit. What's nice is our way of doing that does not require, and in fact it isn't even helped at all by everyone selling their practice or joining a large system. In fact, that added layer of bureaucracy we find just gets in the way. And someone has to pay for it anyway. So we can take practices of all sizes, including solo.
Okay, let's see, the next question is, have you done this? I'm sorry?
That mic.
Okay. Have you done this for any providers in Utah or other western states? What states are you currently working in?
All right, I'll give you our states so far. Not Utah, however, in January, I was actually where a medical convention was, and a couple small private practices approached me and said, can you come to Utah? So I've been approached, but haven't signed any up yet. But we have a growing population in Northern and Southern California. We're working in Texas, Iowa. We're starting to get some input in Nebraska, Illinois, Ohio, Pennsylvania, North Carolina, Florida, Connecticut, Massachusetts. So there's no, the states don't have to be next to each other. Our guess is we're going to be in all 50 states. This seems to offer a fourth option. Back in the 80s, there were also roll-ups to large hospital systems, large practice aggregations, and some are good. Kaiser I like, but I think we can perform at the same or higher level, and we don't have some of the overhead. And then there's the big insurance companies that are buying practices. So those three, large insurance entities, large integrated practices, large hospital systems, were all around in the 80s, and they're around now. What wasn't around was something like us. So we're offering a alternative which seems to outperform or perform at the highest level without giving up the practice and without the overhead that those other three have. I wish them well, but we like our structure because we actually move faster and share more of the infrastructure money with the physicians who we think should earn it.
Okay, how do you incorporate specialists or group practice specialists into your ACO, and would there be any benefit to affiliation of a multi-state specialty network with your organization?
Well, the answer is yes, we do. As I think I showed you in one of the earlier slides, our networks, have to have specialists. But if technically, because Medicare ACOs have unrestricted specialists, all the specialists in the country are already in my ACO. They're just not connected to my tools, but the ACO cannot exclude any specialist. No ACO can. You don't necessarily share the surplus, but you're in the network. In Medicare Advantage, you have to have so many specialists for however many PCPs you have, and we do too. We, as I said earlier, we never have a withhold. We don't do it for the hospitals either. We don't need to. So we actually, for our Medicare Advantage, we start by giving the specialists 105% of Medicare. They don't have to balance bill the part that Medicare doesn't cover. So we're very physician friendly. We also look for specialists in each community, in each area, to help us solve the clinical problems. How do I manage these chronic diseases? Each specialty, and I have an uncle who's an orthopedist, an uncle who's OBGYN, I have cardiologist brothers, I have my father's a pulmonologist, have some surgeons. So basically, you know, in orthopedics, if you manage the osteoarthritis, which sometimes means putting in the device, sometimes not. If you manage, if pulmonary cardiology, nephrology, if you help us manage, then there's no reason why we wouldn't want to have more referrals, more visits, if we can prevent some of the hospital expense or nursing home expense together, or pharmacy expense. Then we, in our model, it's not a shrinking pie. We redistribute so that the specialists get an increase. The PCPs get a bigger increase. They have more unfunded chores, which we want to, get them to do, but also pay for. But none of the physicians in our network see a decrease. And yes, we want to work with multi-state societies and groups. I tend to put everyone under our umbrella and say, here's your part of the budget, can you help?
Does anybody else have any questions? Well, join me in thanking Dr. Gaziano.
Thank you, Dr.
Thank you all very much for inviting me. Book some time to come out and visit. So look forward to it. I'll sign off and let's get back to your meeting. And I thank your leadership and have a good evening, all of you. Bye-bye now.
Next, we'd like to entertain any more questions for Mr. Sandak. Then we'll excuse him if there's no further questions. Does anybody have any other questions about the possibility of, or the discussion on physician unions? Mr. Sandak, do you have anything else you want to present?
Well, just short.
If you think of a question, please bring it up here, please.
Okay, well, I just wanted to thank you again for inviting me to your meeting tonight. There was a few things I didn't get a chance to mention that I just wanted to kind of clean up. When you get if you actually negotiate an entire contract, you cover a lot of items, obviously, the hours of work, the pay, benefits, leave provisions. But there may be some things, the grievance arbitration provision is really quite crucial. So it does, it essentially is the disputes resolution procedure. And you present the grievance. Grievances usually come in two forms. One is when the contract has been violated, and the other is over the disciplinary procedure and the just cause procedure, which I spoke briefly to. So those proceedings, when they're not resolved, it goes to arbitration. And it goes to a neutral, experienced arbitrator. Both parties share the cost and bring the arbitrator in. I deal with arbitrators, frankly, who were provided from a name from the Federal Mediation Conciliation Service. They're all from out of state. I frankly don't deal with in-state arbitrators, but they're experienced and for the most part legally trained individuals. So you win a lot of these grievances, particularly on disciplinary procedures, where the employer has the burden of proof. On contract violations, the union generally has the burden of proof. But you're not just appealing to a higher level of the employer to review the same thing. So it's a real remedy, and it's enforceable in federal court. And as part of that process, and as part of the collective bargaining process, in terms that you might want to seek, you've got some ability to perhaps provide that the employer disclose certain information that might be crucial to you in terms of your pay and things of that nature. So those are things to keep in mind. I know there's a lot of concern about strike, but it doesn't have to come to that. There are other means of resolving labor disputes, informational picketing or distribution of information or publicity. You can even use the media and put pressure on the employer in non-economic terms like that. So I wouldn't, I appreciate the concern that was raised about the strike, but it seems like the situations are too varied to prevent from an organization from truly going forward and trying to obtain these rights that I've addressed. And I hope it works for you, and if I can help you in any way in either organizing or affiliating or with the right international organization and evaluating the units that you might want to work on, I'd be happy to do that. So thank you very much.
Any other questions for Mr. Sandak?
Thanks.
So
We appreciate these experts that have shared comments with us. Please, I know some of you have to leave occasionally or early. Fill out the, whatever color it is, the salmon colored papers, and make sure you turn them in.
Yellow.
Oh, the yellow paper before you go out. Also, please remember to email things to me at pres@utahmed.org, PRES. Also, next we want to kind of move to another arena. So first we've talked about, first I want to say that the Utah Medical Association represents all physicians, however they choose to practice. We want to emphasize that we represent employed physicians, non-employed physicians, private practice physicians, hospital-based physicians. We represent physicians and the patients they care for. And the most important thing that you could take home today is that we're trying to preserve the physician-patient interaction and the care that comes from one physician caring for one patient on a daily basis or on a routine basis. And we want you to be able to be free to do that without corporate intrusion and without other government intrusion. So as we talk about these things, please think about questions that you can send to me or that you'd like to ask, because we will have some open forum time. Next, I'd like to introduce our Executive Vice President, Michelle McOmber, who is very well versed in the legislative arena. She has worked for the Hospital Association before working for the Utah Medical Association. I had the opportunity to be with her both up at Utah's Capitol Hill as well as on a national basis. And Michelle knows every bit of legislation that's going on up at the Utah State Capitol. She knows where it is in committee, she knows what to get it, how to get it done, she knows how to get things passed, and she knows things that we don't want passed, how to stop them. And we appreciate her legislative efforts and her great abilities at bringing these issues to us. And so as we are now done with 2014 legislative session, it's time to think about next year. And this is hopefully a time to think about what we might want to do and what we might want to propose. Also, I can't emphasize enough the respect that our congressmen on a national level have for Michelle, and it was very evident as we went from each congressman and each senator's office how well respected she is there, how often she goes and visits them with each of the different presidents every year. Please welcome Michelle McOmber.
Thank you, Steve. Whoops. Thank you, Steve. I appreciate that. And also, I'd like you to give a hand to your executive committee, Steve, and your current president, Steve. Steve Miller, Dee Allred, and a number of other physicians from our leadership went back with us to Washington a couple of weeks ago, and we did meet with our senators and congressmen. And we did ask them to sign on to certain bills, and they did sign on to certain bills. So we had both Bishop's office and Chris Stewart's office called us before we reached Utah, before we got home, and told us that they would sign on to the bills that we had asked them to sign on to. So it takes a great deal of effort on behalf of your leadership to get some of these things done, and I would like you to give them a hand if you would, please. I just wanted to mention, before I get to Utah legislation or potential legislation, I wanted to just mention that Senator Hatch has been working on a bipartisan bill for fixing the SGR, getting rid of the SGR. And he's been working very hard on that. And just recently, again because of the elections, that's been delayed a little bit, but just recently, in fact yesterday, the Senate and House had passed legislation, House Bill 4302, which is a federal piece of legislation, that extends the current SGR, not the fix, but the payment delay, or the delay in cuts for 1 year until March of 2015. And then it also gives you a 0.5% update. And that's still a temporary fix, but they've done this, and Hatch on the floor said, let's pass this so that we can now get done with an actual fix to the SGR, get rid of the SGR. The other thing this piece of legislation did, by the way, is delay implementation of ICD-10. Was going to go into effect October 1 of 2014. It's now been delayed until 2015. Now, the medical societies all went back and actually asked them to repeal ICD-10 because you're going to have to go to 11 after that. We're not quite at that point, but they did delay implementation again. And that's big, especially for independent and small practice groups of physicians. To talk about a little bit about legislation that we may be proposing, I do want to just go back to some of the issues we had last year. And as you know, we ran legislation in 2013 and ended up pulling that legislation. We are working, and I wanted to mention this, on a white paper with the Hospital Association. If we can get all of the hospitals to sign off on this white paper, it does deal with some of the issues that we had brought up in legislation. Just to give you a brief overview of that, it does address issues of employment of physicians and credentialing of physicians by hospitals. It isn't a signed contract, but it would be an agreement with the hospitals out there on what they would or would not do in certain circumstances. So it talks about employment of physicians, credentialing of physicians by hospitals, recognizing the relationship between physicians and hospitals, and that it's a voluntary and contractual nature, but that there should be certain protections. And so we've been working on this white paper for the last probably 4 or 5 months, 6 months maybe now. It also talks about recommendations for hospital credentialing of physicians, what has to be involved in that, due process, and a number of other things. And so some of these things may be addressed through the white paper if we can get agreement by all the systems. 2 of the systems have been working very well with us. Intermountain University of Utah, we haven't had as much participation yet by Mountain Star and IASIS. However, Steve Miller and I just met with the new guy at Mountain Star, and we think that he hopefully will come on board with that white paper. So we'll continue to work on that. In addition to that, we are obviously, as Steve mentioned, concerned about allowing physicians opportunities to practice in different modes, to practice how they want to practice, whether it's to be employed, whether it's to be solo or whatever. If they can participate and do the things that they need to do in terms of quality outcomes and some of the other things that are mentioned under the Affordable Care Act, they should be able to continue to do that. So one of the things that we are considering, and again, some of this also rests on whether or not we get a real agreement on the white paper and we get the hospitals and the systems to agree and to actually follow through with that agreement in their practices. Some of the things that we're looking at, or that we looked at before, were prohibiting economic credentialing. That is in the white paper. If we can get agreement on that, we may not have to run anything on that. But that could be legislation that we consider again. That would, both on the hospital side and the insurance side, prohibit systems from denying credentialing or paneling for economic reasons. In terms of what it would be is that hospital credentialing decisions would be determined on an individual basis, and they had to be based on objective evaluation of the applicant's credentials, free of anti-competitive intent or purpose. So there are a number of pieces of legislation that we're looking at. That could be one if we don't come to a full agreement on the white paper. We also are looking at, and we have been talking for many years with insurers and systems about any qualified provider participation. And under the ACA, that would be something that we could again and are again discussing and saying that ought to be there, is that if a physician can show that they meet the qualifications that are set up by a system or set up by an insurer, they should be able to participate with that insurer or that hospital. And so we continue to push that, and that may even come to legislation if it's necessary. Again, we're not proposing at this point in time that we are going to run this legislation, but we're talking about the possibility of what we need to see in Utah to protect physicians and to help physicians to move forward in this healthcare environment that we're seeing in this changing healthcare system. So we would hope that, and what we would ask of you, is that, again, these yellow sheets that are on the tables, please fill them out. You don't have to put your name on there unless you want to participate in one of the task forces that we may put together. As you can see, we're saying, should UMA look into forming a statewide, countywide, or other accountable care organization in Utah? And if you're interested in that and you would like to see us do that, please answer yes. And then if you want to participate in a task force that looks at that, please make sure your name is on the paper. Another thing that we're asking you to give us input on is, what are the problems that you're seeing around the state as a physician that maybe particularly have shown up since the passage of the Affordable Care Act? We've heard many, many complaints from physicians on different issues, on billing issues, whether it's an insurance company, whether it's a system, on deductibles, what's happening with deductibles, and whether or not they are being depaneled or not being able to participate in insurance companies anymore, and we are seeing a lot increase in that kind of activity. And so we want to know what's going on. We want you to give us that input so that we can look at what we can do to help with those issues. So that's another question that's on this yellow sheet I'd like you to look at and address if you can. Tell us what's happening to you. Tell us what's happening to your practices, to you individually as a doctor, what have you. And then also, we are looking, we want to know if you want to further explore the possibility of forming a physician union. If you do, it's not on this sheet, but if you do, please, on the yellow sheet, on the bottom of it, say, yes, please continue exploring whether or not we should form a physician union or some kind of physician bargaining organization. Because we want to know what it is that we need to do to help you guys. Some of the other things that we're looking at as possible legislation would be coordinated care organization legislation that sets up some parameters for what that coordinated care would be, whether it's called an accountable care organization, whether it's called a coordinated care organization, or whether it comes under some other heading. Should there be parameters that also give a little bit of protection to physicians and their ability to participate in those? Possibly something about requiring disclosures by insurers and or hospitals on physician selection criteria. We have seen a lot of legislation passed that deals with transparency in healthcare, and that is probably another piece that could be added to the transparency in healthcare. How are insurers or how are hospitals determining who gets to participate? And all we're saying is make it transparent. Let us see what it is. That way, as a physician looks at it and says, wait a minute, wait, I meet all of this criteria. Why am I not qualifying for this? They can go back and discuss that. And that transparency is there, and then The insurer, whoever, needs to have a good reason, and better have a pretty good reason, why they don't qualify if indeed all of the things are met. We could also do things like beef up the network adequacy for insurers in Utah, and also look at certain kind of patient choice under the ACA, and emphasizing the choice that's supposed to be under the Affordable Care Act. So those are just things that we're considering. So another thing on this yellow sheet that I'd like you to fill out is if you are interested in exploring, and we're not saying you would come and determine what the legislative language is, but just ideas that may help physicians. And then we would take it from there in terms of drafting legislation. Please sign up on this list, and we can have you participate in some kind of a task force on that. In addition to Accountable Care Associates, which was the presentation you saw here tonight for physician practices that are small or solo, we think that's one way that we could go. We are also looking at other types of organizations that could help solo physicians or small practices continue to practice, such as forming an independent physician association, like we've seen in some of the other areas of the country, and looking at other kinds of organizations that pull solo or small practice physicians together. So again, we need your input, and we would ask you to fill out those yellow sheets. If you want to get online and do it, we'll have that available on the UMA website as you sign in. After this meeting, we are recording this meeting, so it will be available to UMA members as they sign in. And we want your input and feedback on what UMA needs to do for you, what's most important for UMA to focus on for physicians in Utah. So with that, if there are any questions, I'm happy to answer them.
Michelle?
Yes.
Some of the things you talked about sound familiar to the any willing provider issues we dealt with 10, 20 years ago. Similarities, differences?
Okay. Any willing provider would be that an insurance company would have to let you participate regardless. So you wouldn't necessarily have to meet any requirements. You wouldn't necessarily have to be paneled. You could balance bill, etc. Any qualified provider would be a different approach, in that if an insurance company sets up parameters of here's what you need to be to participate in the insurance, there has to be some piece in there that says if they have network adequacy, some of that plays into it. But the question is there network adequacy in the areas that sometimes claims are made that there is network adequacy? So an any qualified provider would be you set up qualifications. So you say that, okay, you have to be board certified in your specialty. You must comply with these quality requirements that we have if you're going to provide services to our insured. You must participate with our data requirements, and sharing the data back with us. You must do this, etc. And then if they post them and say that that is what is required for you to participate, there needs to be a really good reason why you wouldn't be able to participate. So for instance, again, if we get back to network adequacy, but even that, there is supposed to be a certain amount of choice under ACA, and we want to preserve a certain amount of choice under ACA.
Any other questions for Michelle? No question. Stand up and speak up into the microphone, so all dead. Hello? Okay.
Hold it like this, straight down.
Hello?
Yeah.
There we are. My question revolves around the exclusion of physicians by commercial payers, by HMOs, from contracts such as MedAdvantage. I know that's what we're discussing here.
Mm-hmm.
Could we go at it a different point of view? Perhaps we have a basic patient health bill of rights, so that if you're a physician, you take Medicare, and you're a patient, you want to see a provider,
Mm-hmm.
that despite whether being part of a MedAdvantage plan or not, that you have the opportunity as a patient with a bill of rights to see whatever provider you want to see?
There would be some federal restrictions, and we would have to look closely at that. But that is certainly something that we could explore, and that's the things that we want to hear. We want to hear from you on issues like that. So.
Again, I know it's dying, but clearly this is a game for facility fee money.
Mm-hmm.
And in as much as a large organization can control providers and facility fee, that's what they're interested in doing. And this is an attempt to say, despite those interests, patients still need to be served by the physicians they want to see.
And that's why we're looking for options. So a patient bill of rights would be one thing that we could definitely explore. Now, how far that could go, we'd have to see on the restrictions, but yeah.
For your questions, can you introduce yourself too, so people know on the recorded thing for the website when you're asking a question? Does anybody else have a question? In the back.
Just briefly.
Who are you?
I'm Ray Keaton, family physician down in Spanish Fork, and I'm just coming up here so I can bring this information back to our practice. I want to bring these questions to my more senior partners. I've only been there for a year. And I would like to just get a contact something so we can maybe email these back to you.
Yes.
You can answer now.
Yeah, and as Steve said, you could email it to prez@utahmed.org. You could also email things to me, and I would share them with Steve also. Michelle@utahmed.org. And the last couple of months, particularly, we've been receiving a lot of phone calls from physicians on different issues out there that we want to address, and your UMA leadership is looking at that to see what it is that we can do to help physicians. And that, again, is one of the reasons why we had this meeting tonight, is to discuss some of this and see where we want to go with some of these issues and how we can help physicians. So if you have other things, please contact us. Please email us, Steve or myself, and we will look and see what we can do to help you as a physician in Utah.
Karen Radley, I'm a family physician in Price, Utah. One of the things that just came to my attention, Michelle, is through my sitting on Life Point Hospital Systems Board, is the chief medical officers of the hospital system are being approached about new regulation that the ACA is attempting to draw. And I just want to make sure that the UMA was aware of this so we can start taking a stance on this now. But basically what they want to do is they want to create a nationwide algorithm, a computerized algorithm, that as a physician, if you're going to order any radiologic study, doesn't matter what it is for, period, that you're required to log on to this computerized algorithm process to determine whether or not they feel like the study that you're ordering is deemed adequate. And if you fail to do this, if you're not being tracked in that database and you're ordering studies and they're getting a billion side of it showing that you're ordering and studies are being done and you haven't logged on, that they're going to economically screen out the lower 5% of all physicians who are doing that and drop you from all of the Medicare paneling options. So,
Yeah, government plans, Medicare.
yeah. So I just want to make sure we're ahead of this before this actually gets drafted.
One thing that I wanted to mention about ICD-10, one of the big things that we talked about back in Washington, D.C. with our congressman was the fact that it was costing private practice physicians a lot of money to switch to ICD-10, and that ICD-11 has half as many codes, and that it's on the horizon, and can we just wait for ICD-11? And we're grateful that they postponed it for 1 year. And I did research, and ICD-11 is available in 2017. So we will make this change maybe in 2015, and then ICD-11 will be 2 years later. Does anybody else have any other questions? I'll come to you with the microphone, or any other open forum comments, and we'll address them. We still have some time for the room here. Obviously, we as physicians, one thing I learned from my professors up at the U, he said if we're not doing a good job and you don't find it interesting, certainly go ahead, feel free to leave and go study on your own in the library. So if you're done and you're not getting anything out of it, feel free to leave. But if you have questions, please feel free to ask them either by email or here. Does anybody have any other questions or comments?
I don't need the mic. Hey, Smats and Vernal. This postponing of the ICD-10 on April Fool's Day. We want to come tomorrow and find out if it's a scheduled joke.
It passed March 31, not April 1.
Any other questions or comments? So, everybody can stand up for a minute if they have something they'd like to say. That's what we kind of had in mind for our open forum, to just bring up issues that are affecting you as practicing, especially affecting you in your physician-patient relationship. We want to help improve that and preserve that.
I'd like to just, I probably don't need it, I haven't presented those.
It's nice for the recording.
For the group as a whole, and I've come across this a number of times, and I know others have, maybe this is something that we can look at as a group, but I have certain issues with insurance companies requiring step therapy to use cheaper drugs. In a setting where they're asking us to use drugs off-label in lieu of drugs that are on-label. And I don't know if you've come across this, but I know there's specific situations where we have issues where their insurance companies are asking us to use off-label drugs in lieu of on-label drugs to save money, but yet they are unwilling to take on the liability of using the off-label drug first. I don't know if anybody has those problems, or if it's an important enough issue for the UMA to address this through some process, through legislation or something else that would force these insurance companies to either remove off-label step therapy. On-label, I get it, but for off-label, or at least assume the liability if something goes wrong, rather than putting it on us.
We have heard a little bit about that lately. We've also heard that the same type of argument with not off-label, on-label, but with devices, medical devices and implants and stuff. So we are hearing a little bit of that. Does it seem to be any one particular system or company, or all of them? Okay. We'll look at that too as we look at issues.
Any other comments that you want to bring up?
I would like to ask, so do you think this was a helpful meeting?
Yes.
So if we follow through with, maybe we may have another, a follow-up meeting of some sort where we have other presentations kind of like this. Okay.
I'd like to emphasize, how appreciative we are of all of you and all you do for patients and for each other. Some of us are helping other physicians with studies and with anesthesia and all sorts of things. We help other colleagues and we help other patients, and then we help patients face to face. And we appreciate you being here, and we appreciate the administrators who are here and those who are interested in preserving a good, healthy healthcare system and physician-led teams in our community. But again, thank you all very much for coming, and we will continue to review the things that you send us, and hopefully be ahead of the ball game on any problems that you might be in finding in your practices. And thank you for being here.
And can we have UMA staff stand up? These guys really do all the work for you. Mark Brinton, Mark Fotheringham, Paige, and Kelly that are here. Oh, and Sylvia. Sorry, Sylvia. All right, thank you. I guess we're ending early, which is always good.